What are people's views on national health insurance and its benefits?
Health in South Africa depends upon your pocket, which is very unfair because life is a basic necessity. We'll all have a right to live and to get proper health facilities. So this is going to be great. Kudos to whoever came up with it, and we hope that it actually goes through.
I think national health is going to benefit all of us. It's not about some households because they are unemployed. So it's actually going to help us in order to, when we are sick, we can go to hospital because the national health care it supports us. So because people are so unemployed in a way that they can't afford their basic needs, so that will help even the community as a whole.
I think it is good because it will help those people who are unemployed because they don't have money to go to private hospitals. So it will be good for them.
Not everybody has the same income bracket. I mean, if you check the private institutions and the public institutions, there's a huge gap in terms of service delivery, which puts a lot of people's life at risk. So if we all have access to health in a quality orientated way, I believe that there will be less people who are sick, less people who are dying and us not knowing the cause of death.
South Africa's National Health Minister, Dr. Zweli Mkhize, tabled the National Health Insurance Bill in Parliament about 3 weeks ago. The chairperson of the Portfolio Committee on Health, Dr. Sibongiseni Dlomo, has welcomed the bill. And according to him, under the NHI, government will provide a package of comprehensive health services for free at private and public health facilities as part of its bid to provide more equitable access to quality health care. Since then, the NHI bill has been a topic of much debate. The bill has been met with mixed reactions from various sectors of our community, from severe criticism, qualified or conditional support, to full support as the right thing to do. The debate has unfortunately also left a lot more people rather confused than informed on the subject of NHI. There are many questions around the subject, like, what is NHI? Why is the government pushing it? How will it work? Who is eligible? What will it cost and where will the money come from? When will all this happen? What does it mean for the private healthcare providers? What will happen to medical schemes? These are just a few questions around this subject we will address today. We focus on the NHI. We'll be joined in studio by representatives from the National Department of Health and an array of healthcare industry stakeholders. So these guests are comprised of the Deputy Director General from the Department of Health, Technical Specialist on NHI also from the Department of Health, Health Economist from the Wits School of Governance, the Group Public Policy Specialist from MedScheme, COO of GEMS, Principal Officer of MedShield, Consultant in the Health Minister's Office, Chair of Social Policy and Public Governance, also from WITS, SANAC Civil Society Forum, and in our Cape Town studio, we'll be joined by the Chairperson of the South African Medical Association. And then in our Devon studio, we have the chairman of the Independent Practitioners Association Foundation. Now, you can tweet us at SABC Health Talk or simply interact with us on our Facebook page, SABC Health Talk. So sit back, relax, and learn from this bumper show coming to you just after a short break. I'm Dr. Silla Mutau. This is Health Talk. All right, so to take us through the subject of NHI, it's a great pleasure to welcome two representatives from the Department of Health. First up is Dr. Anban Pillay, who's the Deputy Director General from the department. And next to her is Dr. Akwana Tulare, a technical specialist on NHI, also from the National Department of Health. Welcome to Health Talk, you two.
Thank you.
Good morning.
Morning.
All right, perhaps let's start with you, Dr. Pillay. There's a lot of discussion around NHI. Let's just go back to basics. What is this NHI?
The NHI is a funding pool that brings together funds from various sources to be able to buy services on behalf of all South Africans. So the fund will basically contract with providers in the public and private sector so that South Africans can access services through the NHI without having to belong to a medical scheme. On the other side, the public sector having to be funded through the current arrangements that are in place between provincial departments and the Treasury.
Okay. I know you've already touched on it, but why do we need it? What's new now? What is it that makes us say we need an NHI like right now? Dr. Tulare?
NHI is our strategy, firstly, of moving the country towards universal health coverage. As you know, globally, all countries are saying that we must not leave anyone behind. We must ensure that everyone in the population receives quality health services when they need to without going into financial hardships. So that is the reason why we want to pool funds so that we can buy these services in a cost-effective way, making sure that we do not break the bank in terms of sustainability.
Yeah. So what's wrong with the current health system that we have right now? People might ask.
Well, in the public sector, what we don't have is what we'd call a purchaser-provider split. So we don't have a purchaser of healthcare services separated from the provider. Right. The provincial departments of health are basically both. And so that causes a tension in terms of the way services are delivered, and that affects the quality of services and the way services are delivered. In the private sector, we have a different problem where the cost of services are actually far higher than what people can actually afford. And so we need to fix all of those problems jointly. So we're not just introducing a financing system, we're also introducing reforms to the health system so that it can run more efficiently, because there are a number of interventions that must be put in place before the financing piece actually fits into all of that.
Okay.
You can add. Yeah. So as a country, we are spending about 8.5% of our GDP. But if you look at the health outcomes, they leave much to be desired. If you look at how funding is arranged, as Dr. Pillay has said, we have 49% of our funding servicing 85% of the population, and 50% of the funding servicing 16% of the population. So if you look at that type of situation, it's inequitable and really, really unfair and unjust. And then we need to come up with a mechanism that would ensure that we redistribute this funding so that everyone in the population has advantage of what we are spending as a country. When they look at us as a country, they don't say you are a public sector or you are a private sector. We are one country, and we are trying to create this uniform health system that addresses the needs of the entire population, not fragments of the population.
So people might ask, who are the intended beneficiaries of this NHI? You've just said everybody. Is it about taking the so-called better quality healthcare from the private sector and giving it to people in the public sector?
It is about improving quality health care for both the public and the private sectors, but ensuring that both sectors benefit the entire population. Currently, what you may perceive as a better quality public service in the health service in the private sector only benefits 16% of the population. But even that is called better can be questioned and challenged because there are many, many challenges also in the private sector.
I think it's important to also add that there are different dimensions to quality. And the public, when they engage with the private sector, judge its quality based on its aesthetics, on waiting times, the cleanliness of the facilities, the attitudes of staff, etc. What we don't always talk about is the clinical quality as to what the clinical outcomes are. And I think we still need to move that discussion to that level. But currently we understand that there are issues around the areas that I mentioned, and so we need to fix those because those are critical so that the public have confidence in the public health system.
All right. So let's look at a few scenarios, okay? I'll paint a scenario of three people. We have a Smangele who lives out in the rural areas, lives with about 3 grandchildren. She herself has hypertension, and she has to, get into taxis twice, wake up early hours of the morning to go and get her treatment. in the rural areas. Then you have Sipho, who works for a supermarket out in Johannesburg and is really struggling to make ends meet and is just able to afford being on a medical aid, a so-called low contribution option, and has 2 dependents. And then you have a Simon, who is a CEO of a large company, who himself, has just been diagnosed with prostate cancer, and unfortunately his wife has some chronic kidney problem, is on dialysis and awaiting a kidney transplant. So how will the NHI impact on all of these 3 people that I've just outlined? Dr. Pile?
So we're starting with Simangela, are we?
Yeah.
Okay. In the case of Simangela, I think that she's in a rural area. She wants to access health care. One of her key challenges are transport, because she has to pay to go to a clinic and access care. One of the things we've implemented is a chronic medicine dispensing and distribution program, so that she's able to collect a chronic treatment at a place closer to her home. At the same time, under the NHI, we would contract general practitioners in the area close to where her clinic is, so she could see the doctor, which was nearby, and monitor her hypertension. So she doesn't have to travel to the hospital to get a prescription or wait for the day when the doctor comes to the clinic in order for him to reevaluate her and prescribe her medication. So I think for that patient, that would be a key benefit relative to how the system currently operates.
Mm-hmm.
Yeah.
So let's look at the gentleman who lives in the informal settlement and is on a low-cost benefit option.
Right.
How NHI is going to benefit that individual is that he will no longer be on a low-cost benefit option.
Yeah.
He will be on a comprehensive package of services that would afford him a wide range of services that NHI is going to afford the population.
Yeah.
So we are now firstly removing the burden of paying from a very, very low income base exorbitant fees towards a medical scheme that does not even have sufficient benefits to cover his condition and the condition of his or her children. And what would happen is that normally before the year ends, those benefits are exhausted and they land up in the state. So that gentleman will not be facing that type of problem. And then for the rich CEO who lives in an affluent part of town and who has got prostate cancer, we know that some of the conditions that are supposed to be covered by medical schemes are not covered, or they have to pay on top of that to make sure that they receive the adequate coverage. So with NHI, because it's going to be comprehensive, he will not have to be worried that the prostate cancer is not going to be covered.
Will he still have access to the sophisticated type of treatment
Absolutely.
that he wishes for? Yeah?
NHI will be covering sophisticated type of treatment and the simple type of treatment.
Right.
But it will be determined by the Benefits Advisory Committee, which will consist of a variety of skilled people who will look at evidence-based current interventions and say, this intervention is appropriate for this type of condition.
Yeah.
So NHI is not going to deprive people of a sophisticated treatment. Sophisticated treatment, as long as it's evidence-based and it can be proven that it's cost-effective, it will be covered by NHI.
I think it's important to also highlight that many South Africans, when they listen to the NHI, reflect back on what they currently have as a medical scheme. And so the question to me is often, so how many GP visits will I have? How much of money will I have for medicines, etc.? The NHI benefits are not structured in that way, because in the beginning of the year, in January, your body doesn't tell you, take this option because this is how many times you're going to get sick, these are the drugs you're going to need, etc. So it's important that people appreciate that the benefit structures under schemes are very different from what the NHI will have, simply because, I mean, they're completely different models.
So, of course, there's a lot of things we can talk about here, but unfortunately we have limited time. Let's go back to the plans. Firstly, before we get to, what's planned going forward, the bill has just been tabled in Parliament now. What's next until 2026? But before you answer that question, please let's address the issue of the funding. Where is the money going to come from?
So in the bill, there are a number of funding sources that the Treasury has identified. The first is obviously the appropriations that will come from the general tax revenue. The second is the provincial equitable shares, as well as the conditional grants. A portion of that will be top-sliced and transferred into the fund. The Treasury has also identified the tax credits, which would be reduced over time. And then finally, they've also identified payroll taxes as well as personal income taxes that would be an option. I think when the Treasury produces its paper, they would identify what are those options. But it's also important, I think, to appreciate that it's an economic outlook. We're talking about 7 years from now as to when many of these things will be implemented. And as the economic situation changes, they will then revise that. And I would anticipate that our economic situation will actually change. And so we would actually be able to afford far more services than what we're currently looking at in the current economic climate.
Yeah. Right. So in the last minute, just the plans going forward.
We are going to be continuing with health system strengthening initiatives, ensuring that our infrastructure is improved, that we train and employ more nurses and doctors and frontline workers, that we improve quality in our public health system. The bill will go through Parliament, it will be processed, there will be public consultation processes, and eventually, once we have done that, it will be accented to law. But in the meantime also, we'll be starting with establishing institutions that are going to form part of the fund. We're establishing an office in the department that will be the embryo of a future fund. And that office will be undertaking various interventions to ensure that we have got the capacity and the capability of administering the fund.
Okay. All right. And we have to go for a quick break. When we come back, we try and look at the impact that the NHI will have on various sectors of the healthcare industry, starting with, looking more closer at the funding and administration of the fund, then go on to look at, the impact on medical schemes and medical professionals. But that after the break. Please stay with us.
You've got people salivating in my ear between my director and everybody else at the back.
This is Morning Live.
This is definitely going to be a special project.
So I wanted to create an awareness in Igama about the experiences that black women face on a daily basis that they either can't speak about or they tuck away in their memory.
The more and more women are wanting fit bodies for life, no matter their shape or size, we've been able to tap into that amazing energy.
Welcome back. We're talking NHI with our guests. We've just heard from the National Department of Health. Now it's a great pleasure to introduce our next set of guests, Professor Alex van der Heever, who's the Chair of Social Security from Wits University. Welcome to Health Talk, Prof.
Good morning.
All right. And then, of course, we have Moremi Nkosi. Moremi is the Group Public Policy Specialist based at MedScheme. Welcome to Health Talk,
Thank you.
Moremi.
Good morning.
All right. So gentlemen, we heard what the department has said. Of course, we can't cover everything. We thought that we should, focus on those areas that, may be important for the public out there. Let me start with you, Prof. Looking at the funding model for NHI, what is your position?
Well, essentially there is a technical concern with the proposals because it essentially suggests that it's going to centralize all the funding for health within one structure and it's effectively going to general tax fund it. And that completely ignores the fact that there is a limit to how much you can raise from general taxes. And it assumes that it will raise sufficient funds to substitute for the co-contributions people make on medical schemes on the assumption that that is almost a form of public money. In other words, the money you co-contribute, as for instance, if you co-contribute for private security, that is now regarded, just because you contribute to that, as an equivalent payment for the police force. So the logic in this framework is that because you're co-contributing to a medical scheme, somehow that quantum of money should come into a central fund and purchase care on your behalf. Now, on the one hand, you could make that case. The question is, can you actually technically realize it? And when you examine it, the public finance principles work against this logic, because people co-contribute because they get something back for it. So there is a limit to how much you can raise in general taxes. Essentially, you raise the tax rates too high, your government revenue declines, it doesn't go up. So the idea that you can just raise money and substitute it for a co-contribution is essentially nonsense. And that's one of the key fundamental fiscal constraints to the proposal. Essentially, all health systems in developing countries rely on being able to essentially extract resources out of the country through having people co-contribute in addition to a substantial tax-funded base. Mess with that system, you actually lose money. You don't actually get it. So it's fundamental to resource mobilization.
I'll get the department to respond, but essentially, then what would be, in your view, an ideal way of a funding model? I mean, I take it you don't have issues with the principle of the NHI itself.
I don't know I think that it's absolutely critical that you have a universal coverage model and that you have a strong regime around that, both private and public. And in your contributory systems, you require that government is regulating that very effectively and that it is implementing strong institutions to be able to deliver universal health coverage. The problem in developing countries is you cannot create a single purchaser for everybody. It's just technically not feasible. So the issue is that in all developing countries, you essentially have to develop a mixture of funding regimes to ensure that there's universal access. So your tax revenue that you raise, the money that you do raise for subsidies from high income to low income, must be efficiently allocated, and that must be centralized. The idea that you're going to have one purchaser is what's unsound in this overall framework. You're always going to have in developing countries a range of purchases, and you do not centralize that function, and in particular you don't centralize it under a governance model that is the potential to institutionalize corruption, which is an incredibly dangerous feature of this particular proposal. But it will never raise all the money for an entire system. You have to leverage off at least 3 regimes in any health system in a developing country. What you can do in the Netherlands, what you can do in the UK, you can't do in South Africa.
Well, perhaps we need to get a response from the department, or anybody else for that matter, on some of the issues that Professor van der Heever is saying. Yeah? And of course, we're talking to Dr. Nicholas Crisp, yeah?
Yeah, thanks very much. Yeah, I think we're working from the point of departure that the money that is currently in the system is all efficiently spent, and it's going to continue to be spent at that rate to do what we want to do. I think we can all accept that both in the public and the private sector, there are huge inefficiencies. In the public sector, we can quote things such as over-expenditure on human resources, where we pay people to work in the public sector and then allow them to work in the private sector, even during normal working hours, for example. And in the private sector, we are about to receive the Health Market Inquiry Report, where we've already seen from the draft there are a lot of overspending that is taking place in that environment. So it's, I think what we do need to understand is we already spend 8.5% of our GDP on healthcare. We have a pretty big GDP as it is. And the challenge at this stage is not to see whether we can spend more money on more people, but more to see how much efficiency is there in the system so that more people can get access to the same resources.
Anybody else wants to add? Moremi?
So, thanks a lot. I think the one thing that I just wanted to emphasize is that we need to be clear that what's outlined in the white paper, in the NHI bill, is principles around how NHI is going to be funded, right? But I think at the briefing, when the minister was releasing the bill itself, he actually indicated that there's going to be an NHI financing paper that's going to be released by the National Treasury. And I think it's important that this conversation takes into account what's in that financing paper. Unfortunately, that paper has not been released. But I think, I get what Alex is saying, right? But I think it's the principles that are outlined in terms of where the money is going to come, but how that money is going to be mobilized and the details around that, I think will be provided by the Treasury paper. And I think we need to also take into account that that information is soon to be released, and we will have the opportunity to engage with those details.
No. Your last word on this, because I see you dying to say something.
Yeah, I mean, first of all, in 10 years, somebody hasn't managed to produce a financial feasibility analysis. So the HMI report is going to be very important because it's actually talking to how you stabilize the private system. You don't stabilize it by undermining its coverage. The issue is that there are huge problems, and government has a responsibility to regulate the private sector properly. And what's happened is that over the last 10 years, government has failed to regulate the private sector. It's actually pulled back the regulation of the private sector instead of doing its job. And that's in fact what the HMI has indicated. And what it is recommending is a number of systemic reforms that will get that right. You don't get it right just by saying, well, we'll put in a number of simple measures and we'll improve contracting. You require systemic interventions, both in the public and the private sector, and they're not there at this point, and nobody's looked at them in the last 10 years.
I'm going to have to give the department a chance to respond, but please in less than 30 seconds.
I think it's a myth to say that in developing countries, you cannot have a health financing system that creates one pool. There are developing countries that have created that, and I think we should avoid being fixated on a system that perpetuates fragmentation. Because if you are fragmented, you cannot benefit from economies of scale. So one of the reasons why probably systems are not functioning properly, it's because they are structured such that they perpetuate, disparities between those that have and those that do not have. NHI is based on the principle of social solidarity. We look after each other. We make sure that we take advantage of one pool to drive down costs. Okay. So it's not true. It's a myth.
All right. Okay. Before we run out of time, we'll come back to that, if we do have time. But Murema, I need to just find out from you. We're talking administration here of the fund, and you're representing Met Scheme as an administrator. Firstly, what is the Met Scheme's position on the NHI, and how do you see administration going forward?
So, Met Scheme is unequivocally in support of universal health coverage, right? And I think we've put out a number of statements that actually are in support of government's progress around publishing the policy itself, but also publishing the NHI bill, and have submitted detailed technical comments in relation to where we think there's opportunities for improving the way things are currently structured. I think the discussion should actually not be about whether one supports universal health coverage or not, but it's about the details that inform how we actually get to universal health coverage. And one of the things that one always comes up with is, I think, what's the relation that's going to exist, the relationship that's going to exist between medical schemes, administrators, and the NHI funds. In the NHI bill, there are provisions around regulations that will be implemented around how that relationship will exist. But I think the lack of that detail in itself creates uncertainty in terms of, okay, so then what's the structure and what's the evolution of the medical schemes industry, administrators included as well, in terms of between now and 2026. But I think the important thing is there still exist opportunities through the parliamentary public comment process for one to put into place comments and options on how best things can actually work. I think the NHI fund will need a lot of back office functionality, and I think there's opportunities for administrators and medical schemes within that type of environment. But the lack of detail itself makes it very difficult to actually determine how best things are going to evolve over the next 7 years.
All right. I'm going to also invite a comment from the department in terms of the future of medical aid administrators, because there's this notion that there's a lot of expertise that resides within medical administrators because they've been doing this for many, many, many years. And in terms of how then the department sees collaboration, if any, with the medical aid administrators as we're going forward. Dr. Pune?
I think the administration part of the fund is a large part of the work that needs to be done. We currently don't have an administration unit within the fund, and we'd have to build that. And the options that you'd always have in building one is to understand whether there are resources out there that you can actually procure, or whether you'd want to build it from scratch. And I think that'll be the business case that we'd have to make in each case, whether it's for payments, whether it's for contracting, etc. So clearly there are skills and resources in the private sector, in the administration sector, etc. So they would make themselves available, I'm sure, when we're going through those processes of procurement to understand how best we can do that. So I think over time, this will probably play itself out in terms of how the administration would look. I also want to just deal with this issue about that it's a central fund and everything will be paid out of a central fund sitting in Pretoria. I think that's not the way we see it happening, because I don't think that will be a workable model. There'll certainly be subnational offices in order for these kinds of payments to happen. It's a central fund, meaning one fund, but it doesn't mean it's one office with people sitting only in one place having to pay out the administration. I think you have administration like MedScheme has, but they don't have one office sitting in Johannesburg. They have subnational offices to effectively make payments. Yeah.
Okay, all right. Unfortunately, we've run out of time. We will come back, and for everybody will have an opportunity to comment on some of the issues that we've been discussing now. But time for a quick break. When we come back, we'll continue our discussion on the NHI. Please stay with us.
The women and the children of this great country are under siege.
I can hear the cries of women in the streets.
Women are dying with protection orders in their homes.
Women face the onslaught of an oppressor with a different face.
The scourge of violence against women is a dark stain in our nation.
I stand here today and I think of Valencia Farmer. I think of Uyinene. I think of Jesse Hess.
There must be harsher punishment for rape.
We've been mourning, we've been sympathizing with the women that were raped in our country.
Gender-based violence has reached extreme levels which can no longer be tolerated.
Don't strike your sisters. They are the mothers of tomorrow.
Our mothers have cried, our sisters have cried, our daughters have cried, and we are saying enough is enough.
Welcome back, and thank you so much for staying with us. This time we're discussing, obviously we're discussing the NHI, but focusing more on the medical schemes. And our guest in the segment is Dr. Stan Molwabi, who's the COO of the Government Employees Medical Scheme, or GEMS. Welcome to Health Talk, Dr. Molwabi.
Morning, Dr. Mdong.
All right. And then we have Tanisha Naidu, who's the Principal Officer of MedShield. Welcome to Health Talk, Tanisha.
Morning. Thank you very much for having me.
All right. So perhaps let's start with you, Dr. Molwabi. There's the notion that, the NHI is going to be this one big medical scheme that will wipe out all existing medical schemes. But firstly, just give me your official position from GEMS in terms of, your stand on the NHI.
Well, the Government Employees Medical Scheme has always been clear on supporting all efforts towards ensuring that we move towards universal health coverage. Yeah. The NHI is obviously the funding mechanism that has been decided upon by the government, and we continue to support via inputs into the various initiatives of government as we move towards universal health. So we're very clear on our stand.
Okay, so it's unqualified full support. Do you have any areas perhaps of concern or areas that you think there could be further considerations going forward?
Well, in a project as big as this one, there's no way you can be perfect. Yeah. So obviously the consultations will continue, and funding, the funding mechanisms were discussed earlier on. How the fund will be administered has been a matter of public discourse. One of the things that are mentioned is the strengthening of the healthcare system as part of moving towards universal healthcare. And one thing that is for certain is that there are areas that need to be dealt with. They always talk about the 4 S's: the staff, which is the people, the staff spelled with a U, the systems, and the space. All those things, space is the infrastructure. So there has to be attention into ensuring that there is improvement, and I think that is where discussions can continue in terms of moving forward. But I think what stands out for me at the moment is the fact that we are going to be in a transition period, and whenever one moves from one legislation to another one, it does help when the transitional arrangements are stipulated either in what becomes the new legislation. It can be via regulations that are attendant to the Act once the bill becomes an Act, or it can be via gazetting, the processes of what are the transitional arrangements. So at the moment you find that there is a bit of uncertainty as to what is going to happen until NHI is fully implemented. And I think that's an area that may need us to really look into.
All right. Let's get the view from MedShield. I mean, there's this notion that once NHI is implemented, medical schemes will cease to exist, or they will play a very small role. What is your position in terms of, the NHI?
Sure. Thank you very much. So firstly, MedShield is very supportive of the universal healthcare coverage model. And we believe, NHI bill is one way to access equitable healthcare for all South Africans. So the question around what's written in the bill is what is complementary services? By the time NHI is fully rolled out, it's stated that medical schemes will be allowed to only provide complementary services. But we're trying to understand what is complementary services. Where does it include specialists? Does it include oncology, etc.? And I think as we partially co-create this we need to understand what is our role. And I think given understanding that by the earliest it would be 2026, it gives us 7 years to understand how this model will unfold. In my view, nimble and innovative companies who are able to take the opportunity of co-creating can also define what is the innovative models in this new era. And we've got 7 years to unpack that and adapt our systems and our business models around it.
Do you have any specific ideas going forward?
So I believe from what I've heard and what I've read is the first phase of the UHC or NHI will be primary healthcare. Now I think when primary healthcare is rolled out, the opportunity between now and then is for the government and the state to work with the medical schemes who live in this environment, have experience in primary healthcare and delivering it. And we would probably be able to share lots of lessons of how to expand this throughout South Africa with quality and make sure there's measures in place. So I believe there's opportunity to work together. And then what we'll try to understand is where actually would that line be for complementary services. And the other question is regarding to access NHI, you'd have to go through referral paths. So you'd have to go to see your GP to access a specialist. And the question is, if you go to your GP and you can't access your specialist and you want to go to somebody else, will that be covered by NHI or not? I think, and will that be allowed to be covered by medical schemes? So over time, we'll see medical schemes innovate to offer potentially specialized insurance products for cancer or for orthodontics or those type of services.
Yeah. Dr. Malabi, before I come back to, get a word or response or two from other people, there's this notion that some medical schemes are already positioning themselves for NHI, understanding what the future holds for them. Your comment on that?
Generally, people you don't jump into a bathtub without testing the warmth or the temperature of the water. So what happens is there's a lot of work that we are doing at GEMS, which basically would be what would be relevant in an NHI environment. Shall I give an example? We talk about the bias towards primary health care, which is what is expected, because we know one of our biggest problems at the moment, why health is so unaffordable, is because of the hospice-centric nature of our healthcare systems. So what we have done a lot of work around primary health care coordination, and we are already seeing the benefits in one of the options that has been packaged in a manner that it should have what we think maybe a basic benefit package, which is the minimum that should be available in an NHI environment. Through that work, we have already realized cost savings, and also an improvement in healthcare outcomes. And we see this through less people who would normally be admitted into hospital, not being admitted, but being managed by the general practitioners, without even being referred to the specialist. So this is not conjecture. It's actually, we have proof of that. I mean, we have realized savings up to 17% in the hospital environment through care coordination, through the bias that we towards the GPs, and also through the referral system, where you don't just directly go to a specialist, even when you're just, having a headache.
Okay. Oh, so anybody is welcome, obviously, to say a word or two. Do I have Mabalane, who hasn't?
Yes.
Yeah, Mabalane from this.
Yes, yes, Doc. I think, for us as civil society, there's a few non-negotiables, right. And that NHI is our path towards universal health coverage. It's about social justice. It's about righting the wrongs. It's about breaking the bridges that were created when in 1994 there was a negotiated settlement. We cannot have a situation of perpetuating the injustices of the past. We're not interested in having technical debates about potential corruption. I'm sure there were those people in 1993, 94 were saying the electoral system is going to be corrupt. But it is what it is. It delivers elections, every 5 years. May not be perfect, but that's basically how we're going to want to move. And this notion of voodoo economics that people come up with, people are not working, the NHI is not going to be sustainable, and so forth and so forth. It's not going to help. It's not going to work. We need to do what those who were sitting in the many rooms in 1994 did. It's either they wanted South Africa to work or they didn't want South Africa to work. Yeah. And I think we're all agreeable that we want to right the wrongs of the past and ensure that people are provided with healthcare coverage, and the NHI is a platform that is going to deliver. And we'll all be there to ensure that nothing is done to ensure that that which we want to see happen, people getting healthcare, quality healthcare, to continue. It can't be for some, it must be for all of us.
Yeah. All right, okay. So do I have an indication that we have a comment from our Devon studio? Professor Morgan, Chetty, are you there?
Yes, I'm here.
All right. Do you perhaps want to give a comment or two on the discussion so far?
Yeah, I think it's important for general practice. I hear this debate all the time, and I hear discussion about the future role of the general practitioner. But the general practitioners are really concerned about what this role is and the impact of this role. At present, in the present health system, the general practitioners are afforded about under 6% of the GDP on health. We don't seem to be having the ability in the past to have enough discussion with many of the schemes. We have with some of the schemes trying to get a more integrated, coordinated platform. What we see is that it is nice to be sympathetic to general practitioners, but nothing is being positively done. So the idea of a general practitioner out there says, we need to look at NHI because we don't think it's going to get any worse than we are at the moment. So I think we should move away from the rhetoric of being sympathetic to general practitioners and sit around trying to be more constructive and positive of the role in going in the future. If in a third world economy, primary care is going to be the pivot to where we move forward. So right. I think there's a lot of debate that needs to be engaged in, and I think this debate for me should occur one-on-one and shouldn't be a debate that should be occurring through social media.
All right. Let's give an opportunity to somebody back here in our studio, Professor Ravi.
Thank you. So my starting point would be the value proposition of this NHI bill, and it talks specifically about social solidarity, which I think is a crucial policy underpinning of the proposal, because it's what we don't have in our society. Even in all the years of our post-apartheid settlement, we haven't had a policy that explicitly commits our society to social solidarity, which is about redistribution of resources between the haves and the have-nots, and ensuring that all citizens in the society have access to basic forms of care. And so that's why I think this is significant. Also, and where I would disagree, in fact, with Alex, around the British National Health Service is, in fact, we're a middle-income developing country, so there's more policy space to entertain new kinds of ideas. And anyway, this NHI bill recouples us with the previous policy agenda, the far more significant one in some respects, and even this NHI bill, which was the Gluckman Commission on the National Health Service, which explicitly argued for the nationalization of the healthcare service to meet the needs of all citizens in the context of then of segregation South Africa. And Gluckman argued that a precondition for establishing a healthcare service that is led by primary healthcare delivery is for the healthcare resources to be held by the state, to be taken out of the provinces. And the then Smuts regime, the white minority regime of the time, torpedoed those proposals. So I think we actually do have a policy history in the country, Alex, where these ideas of a national health service, which is what I would be arguing for the past, in fact, 21 years, allows us to think about healthcare as a value proposition, and most importantly, and distinctive as a social policy, that it draws together the interests of all social strata in the society.
Right.
That the middle class and the working class have been invested in the defense of a common public good.
Okay.
And that is what's significant about this proposal.
Okay.
Thank you.
Unfortunately, there is just so much to say, but so very little time. I do know that you need to say something, Prof. van der Heever, but unfortunately it's time for a quick break. When we come back, I promise I'll give you an opportunity, and we'll also cross over to our Cape Town studio to give Dr. Koontz a chance. For now, quick break, and we come back. Please stay with us. Welcome back. We're having this fascinating discussion, very informative, on the NHI. And of course, we've had all our guests here from the Department of Health, Dr. Anban Pile, who's the Deputy Director, and of course, we still have Dr. Nicholas Crisp, who's a consultant in the Minister's Office. But for now, we're going to cross over to our Cape Town studio and speak to Dr. Angela Koontz. Dr. Koontz is the President of the South African Medical Association. Dr. Koontz, can you hear us? And welcome once again.
Yes, I can hear you.
Great stuff. Now, we obviously have been listening to this fascinating discussion on NHI, and then there's the issue of obviously what you represent as the South African Medical Association. What is your position, number one, on the NHI, and how do you see medical professionals going forward?
Well, SAMA supports the universal health coverage. There's no doubt about that. If the NHI is the funding model that the government has chosen to drive it with, then we have to look at how they're going to do that, and we need to make sure that we keep government responsible and accountable to make sure that there's not corruption in this driving model of giving funds to a universal health care model. I also realized that while we are using terms like universal health care and NHI funding, a lot of the times the average person out there doesn't understand the terms that we are using. So if I can make it very simple and say that patients' biggest fear currently, especially in the private sector, is will they still be able to see their GPs? Will they still be able to have a medical scheme? And then also from the public sector, the biggest problems that we have there from our patients is what is going to happen if I really get sick tonight? Am I going to sit in a long row? Am I going to see a doctor? How long is it going to take us? So from SAMA's viewpoint is primary health care is absolute, as Dr. Morgan said, the pivot of this healthcare system that we envisage for all our members and all our people out there. If we don't get it right at primary level, that is the first entry where you as a patient go to see your doctor and go to the clinic. Then we can forget all the debates about how much money is needed and what else, because it is what the patients want and what our public out there wants. And our doctors want to know that their jobs are safe. They want to know that they will be able to see their patients. They want to know that they will get paid. They want to have job security. They don't want to wake up one morning and hear that they are now going to be obliged to see patients from NHI. And we need to send the correct information out there, because there's a lot of misinformation.
All right.
Just on my comment regarding doctors are going to be forced to see NHI. You as a general practitioner will have a choice. You as a patient will have a choice. And I think if we can understand that these choices, it's not compulsory, it's choices.
All right. Let's for this, we're seriously running out of time, but I need to cross over to our Devon studio and speak to Professor Chetty one more time. There's threats or reports in the media that once NHI is implemented, you're going to see a lot of doctors immigrating from this country. Your quick comment on that, please.
I have a lot of interaction with doctors, and I must say I find this quite a very sort of controversial statement. I don't hear doctors in my area and in the country that I talk to all talking about immigration. I think the doctors have other concerns. It's not about immigration. They want to know about certain outstanding information, and we as an organization have decided not to be reckless and irresponsible in making any statements.
But we now have seriously run out of time. I'm going to give Professor van der Heever a chance to say a word or two, and then we wrap up from Dr. Pillay in the department. Yeah?
Yeah, so I think one of my concerns in the discussion on NHI is that there's almost a lot of mother and apple pie. People just state, we're going to do this, we're going to do that. And it's quite cartoonish, a lot of the discussions on the design of the health system. The issue is that anybody can draw a picture of an aeroplane, not everybody can build one. And when we're talking about building, it's the technical issues you have to consider. Health systems are complex. We are going to have, in the next 50 years in South Africa, a hybrid regime of three different, at least three different schemes funding South Africa. It's not going to be one. That is a practical reality in South Africa. And if one doesn't build that into one's design of the health system, then we're going to have a failing health system. Right. And I think that is a key message. We can't basically go on cartoons.
Okay. Final opportunity, 30 seconds, literally, from the... Yeah?
I think it's important to appreciate that the NHI is going to be implemented in stages.
Right.
The first phase is focusing largely on primary care. And the idea is, as we improve on access to care at that primary level, we'll expand to the other levels of care. And people will actually see the changes in quality, which would then build the confidence, I think, that the public need on the National Health Insurance.
I'm afraid we've run out. I really wanted to give you an opportunity, but unfortunately we've run out of time. And for you guys at home, thank you so much for watching. And to all of the participants in this program, thank you so much. Until next time, please do take care.
You're locked on to the